Good afternoon, everyone. I'd like to present my paper on primary iris cysts at the pupillary margin, a rare clinical entity. So, 35-year-old female from Goa, a homemaker married, presented to our outpatient department with history of noticing black masses in both her eyes. In the right eye, she noticed them since the past 10 years, and in the left eye since the past 4 years. She had history of low vision and involuntary movements in the right eye since the past 3 years. So on examination, a vertical nystagmus was seen in the right eye, which was present in all directions of gaze, with the vision in the right eye measured on Snellen's chart was 6/60 and in the left eye was 6/6. On slit lamp examination, globular masses were seen at the pupillary margin in the right eye from 2 to 4 clock hours and from 6 to 10 clock hours, which occluded the visual axis in photopic conditions. Similar masses were seen in the left eye, which did not occlude the visual axis. The intraocular pressure measured was within normal limits. The patient was then dilated using tropicamide. Both the pupils were seen to dilate to 5 millimeters. And in the right eye, the masses were now seen to, which initially obscured the visual axis, moved away, and there was an improvement in vision from 660 to 618. A fundus examination done was within normal limits. The patient then underwent an anterior segment OCT, where these masses were shown to have highly reflective margins and low reflective center, which suggested a serious cystic content. Entire systemic evaluation also was done. A blood workup, including a blood routine, renal, renal liver function test, autoimmune and inflammatory markers were done and found to be within normal limits. A chest X-ray and ECG also done was within normal limits. Our review of literature showed that in these patients, the smooth muscles in the iris and in the aorta can be affected. So a patient was then underwent an 2D echocardiography, and a flap was documented in the descending aorta. A cardiology consultation then taken was, patient was asked to undergo a CT angiography. Unfortunately, the patient was lost to follow-up. Intervention was planned in the right eye because of the history of decrease in vision. The intervention plan was NDX cystotomy. So after taking appropriate consent from the patient, 2 shots of 0.9 joules was fired in an undilated pupil on the cyst located at 6 and 10 clock hours. There was instant collapse of the cyst with release of clear fluid and few refractile particles seen in the anterior chamber. In 20 minutes of the procedure, there was acute rise in intraocular pressure, with the cornea becoming hazy and the pressure rising to 40 millimeters of mercury, which was then managed medically. At a 2-day follow-up, the cornea had cleared up and the cyst walls were seen at the pupillary margin. The visual axis, which was initially obscured, had cleared up and the vision had improved from 6.9 to 6.6. So our review of liver literature was done, where Shields suggested that the cause of these was a failure of closure of the primitive optic cup. Classification, they were classified as primary and secondary. Primary further classified as epithelial and stromal. Epithelial further classified as central, mid-zonal, peripheral and free-floating cysts, with the central cyst being the least common. A familial association was documented by Cohen in 1936 and Ahalya in 2023, and it was suggested that there could be a mutation in smooth muscle because of its association with familial thoracic aortic dissection, iris foculi and livedo reticularis. The main differential diagnosis of this lesion is a iris or a ciliary body melanoma, with the gold standard in investigation being UBM. The complications are mainly due to increase in size of the cyst, including corneal edema, uveitis, secondary angle closure glaucoma, secondary pigment dispersion, and the management is mainly determined by the position, size, symptoms, local extent, growth, complications. And the treatment modalities initially ranged from surgical removal to mycin C injection into the cyst to needle aspiration through intercystic ethanol irrigation to laser photocoagulation. So in conclusion, these are uncommon lesions which can mimic an iris melanoma. Screening is required for cardiac comorbidities. Simple OPD-based procedures such as NDX cystotomy can be used to treat the symptomatic cysts, and post-cystotomy rise in intraocular pressure must be anticipated and managed. Thank you. These are my references.
Thank you.